Okay, so we shall begin. Okay. Okay, sure. My name is Lim Lik Thai. I'm currently a professor in the University Malaysia Sarawak, UNIMAS, which is the government university. And my subspecialty is in vitreoretinal surgery as well as glaucoma and also cataract. So I've been invited to sort of like moderate this meeting by Aurolab and its representative, and it's a great honor and pleasure to meet and welcome you, Dr. Madhu. I would like to formally introduce you, Dr. Madhu, to the audience. So, Dr. Madhu Shekhar graduated in medicine from Rajendra Medical College, MS, from Padma Medical College, followed by fellowship in Cataract at Aravind Eye Hospital, Madurai. Dr. Madhu Shekhar holds his MBBS from Rajendra Medical College, Ranchi, and MS in Ophthalmology from Padma Medical College. He also did fellowship in IOL and anterior segment microsurgery at Aravind Eye Hospital, Madurai, and worked as a medical consultant in cataract and IOL services, Aravind Eye Hospital, Madurai since 2010. Without further ado, I would like to invite Dr. Madhu to share with us regarding the topic on clinical performance of continuous range of focus and multifocal IOLs. Over to you, Dr. Madhu.
Thank you, sir, for a nice introduction. So, I will not take much time. I did my fellowship from Aravind Eye Hospital, Madurai from 2008 to 10. Am I audible, sir? My voice is clear?
Yes.
Slide is visible?
Yeah, slide is playing. Yeah.
Yes. So, I did my fellowship from Aravind Eye Hospital, Madurai from 2008 to 10. And from 2010 onward, I am working as a consultant at Aravind Eye Hospital, Madurai in cataract and IOL services. I am specialized in anterior segment and cataract and IOL services. So my expertise in biometry, dealing with complex cases, and teaching and training. Okay. And so today I will talk about that advanced technology of IOL, that is about multifocal IOL and continuous focus vision IOL. So I am going to start my presentation. So I will just talk about a few inclusion and exclusion criteria for combining both multifocal IOL for Aurolab Dfine and extended depth of focus IOL. Okay. So age for inclusion criteria is around 35 to 70 years. Both gender we can include in this inclusion criteria. We can perform with this IOL in both male and female patients. And patient with bilateral cataract and willing to implant the same IOL in both eyes. Sometimes we are doing mix and match. Also, few studies has shown mix and match of both multifocal and vivid IOL also. But we prefer to use the same IOL in both eyes. And for inclusion criteria, corneal astigmatism, we have kept it for against the rule if it is less than 0.75 diopter, and for with the rule and oblique astigmatism, we have kept less than 1.10 diopter. So above that, we can think of some toric platform with multifocal or EDOF IOL. And IOL power available is around from 18 to 25 diopter. And we have to select patients who are highly motivated for having good near vision and intermediate vision. And they are previously they are bifocal user and able to understand the neuroadaptation. Neuroadaptation is very important because sometimes few patient takes lesser time, few patient takes longer time for neuroadaptation. So for exclusion criteria, like some of it will relative also, some will be absolute also, but I have just mentioned about first absolute exclusion, like any corneal scar irregularities or corneal disorders. And corneal astigmatism, if it is more than one diopter, better to go for toric platform instead of just multifocal or EDOF IOL. Any complicated or subluxated cataract where you feel that centration of IOL is not proper, or there is some associated posterior segment pathology. And this also people, if it is very small and or very large or irregular people. So very small people, that peripheral rings will be not utilized properly, and very large people that will cause of glare and halos, and irregular people also will cause of glare and halos. So we should avoid that type of cases. And any previous refractive surgery cases, we can avoid this type of like premium IOLs. And any retinal pathology which we can anticipate poor visual prognosis due to retinal pathology, like diabetic retinopathy with macular involvement, or optic nerve pathology, or ARMD, where you feel that prognosis is poor. In that case, we should avoid this type of premium IOLs like multifocal or vivid IOL. And relative exclusion is glaucoma. Glaucoma, because early glaucoma we can consider, but advanced glaucoma where field of vision is constricted, and that contrast sensitivity is also less. So in that type of cases, we should avoid multifocal and extended depth of focus IOL. And as I told, like journal weakness, pseudoexfoliation, where late post-op, that chances of IOL decentration or that sensation is compromised. So that type of cases, or uveitic cases, sometimes in uveitis cases, that chances of pigment dispersion or deposit over IOL, that can also hamper vision in this type of, and it will reduce the contrast sensitivity. And any ocular surface disorder. So we have to first treat the ocular surface disorders, and then we can go for this type of premium IOL. Any strabismus like a squint patient, or any impaired ocular motility or vision anomalies where benefit of these IOL will be compromised. So we should avoid this type of, or any patient with cerebrovascular accidents and other eye, if it is monofocal, but patient is very much motivated for other IOL, for multifocal or EDOF, then we can go. That's why we have kept in relative exclusion criteria. So coming to lifestyle and occupational exclusion for both multifocal and EDOF IOL, like patient sometimes type A personality patient with unrealistic expectation and perfectionist in professional. So that type of patient we should avoid, like where their expectation is very high, and then sometimes that patient will create problem in post-op if they don't get their required near or intermediate vision. So better to avoid that type of patients. Job which required very high level of contrast in dim light, like pilots, professional drivers, or where the chances of glare and halos will be there, like night drivers or professional drivers. So that type of patient we should avoid using this type of multifocal IOL. And professional photographers also, where they want a very good contrast sensitivity. So that type of patient we should avoid. And job which require highly precise near vision, like watchmaker or jewelers or very fine worker. So that type of patient also we should avoid using. We can go for either advanced monofocal or monofocal IOL for this patient. And other exclusion criteria for with lifestyle or occupation will be like job which required highly precise far vision, like sharpshooters also we should avoid this multifocal IOLs and EDOF IOLs. So coming to pre-operative investigation, which we should keep in in our pre-op workup, like visual acuity is important and refraction, both subjective and objective. Good slit lamp examination, dilated fundus examination to rule out any posterior segment pathology. Good slit lamp examination to look for, and we should just look pupil size also in undilated state, so that we can know that whether pupil is very small or mid dilated or irregular. And dilated fundus examination, and eye trace, if you have facility of that eye trace. So this is one machine which gives you angle alpha and kappa measurement. But angle alpha is not that much important. Now we are considering angle kappa is more important. So in further slide, I will just go through that what is angle alpha and kappa. And we should always do OCT to rule out any macular pathology when you are going for this type of multifocal or EDOF IOL, where we are promising patient for good near vision or intermediate vision. So better to rule out any macular pathology in this type of patient. And post-operative, when we are after surgery, if the patient are coming for follow-up, so we have to record that uncorrected distance, intermediate and near vision for all patients. And we will see the reflection also, whether any some correction, some cylindrical correction patient is taking, or for EDOF IOL, some near vision correction patient may require. And slit lamp examination where IOL is well centered, or any early PCO or anything like this type of multifocal IOL. If patient will have some early PCO, then sometimes patient will complain some glare halos or decrease in contrast sensitivity. And always look for dilated fundus examination also, at least on day one, first 1 month follow-up fundus examination to rule out any macular edema. Sometimes if cystoid patient develops cystoid macular edema post-operatively, that will also decrease their near vision and contrast sensitivity. And we can have some questionnaire if required. Based on that, we can have that patient satisfaction level, whether they are having glare and halos, or next group of patient, we can use that tool to implant this type of IOL more confidently. So as I told that from eye trace, we are seeing both angle alpha and kappa. So, but angle kappa is more important, and just we will just go through that 3 axis of eyes. Axis of eyes, one is visual axis, where line is passing from fixation point to fovea through nodal point of eye. That is a dynamic. This axis is dynamic axis which pass through fovea of eye. This is visual axis. Optical axis is the center of the anterior and center of anterior pole and posterior pole, which connects that line connecting both center of anterior and posterior pole, passing through nodal point of eye, means center of that limbus. That is called optical axis. The line passing from center of limbus is called optical axis. Pupillary axis is the center of your pupil. So what is angle alpha? Angle alpha is found by this axis between visual axis and optical axis. Visual axis which passes from line passing through fovea, and optical axis from center of nodal point. So between this axis, if angle is formed, that is called angle alpha. And angle kappa is angle between visual axis and pupillary axis. Between visual axis and line passing from center of pupil, that is called angle kappa. So in this figure, you can just make out that this red line denotes, green line denotes visual axis, red line denotes pupillary axis, and that blue line denotes optical axis. So line between that optical axis and this one pupillary axis is angle kappa, and between angle between optical axis and visual axis is angle alpha. So how this has clinical application when we are using that multifocal IOL? You can see that in this picture, down picture, that when we place IOL, we will place mostly in the pupillary center, and this like angle alpha should be less than 0.5 millimeter. If it is more than 0.5 millimeter, then if you place the IOL in the pupillary axis and your distance is more than 0.5 millimeter, then one of the ring will fall on this. If you have placed on this pupillary axis and your visual axis is this blue line, so visual axis is dynamic axis, whereas like it will be not fixed with that optical axis and pupillary axis. But when we are placing IOL, we will place either in the center of your limbus or a center of the pupil. If this distance between visual axis and pupillary axis is more, then one of the ring will fall on this axis, and then it will cause of glare and halos. So that's why for clinical implication, we can select patient with less than 0.5 millimeter of angle kappa or angle alpha. If it is more, then we should avoid using this multifocal or EDOF IOLs. So coming to this multifocal IOL, which is by Aurolab, it is called Aurolab Dfine. So it is a multifocal IOL. Add power is +3 diopter. It has apodized diffractive optics. Apodized diffractive optics means all diffractive IOLs will have height of that diffractive zones. So if height is similar, then it can decrease the contrast sensitivity. So when this with the apodized diffractive zone from center to periphery, the height of the diffractive zones are reduced, so that equal distribution for distance and near will be there, and there will be less means decrease in contrast sensitivity. So contrast sensitivity will be better in apodized diffractive optics. So in this multifocal IOL, there are 11 rings, and diameter of diffractive zones are 4 millimeter, and energy distribution is 47% for distance and 35% for near at 3 millimeter pupil size. And as I told, apodization helps the lens being distance dominant under low light condition, and there will be less loss of contrast sensitivity. So why this 3 diopter? Why not 2.5 diopter or 4 diopter? You can see that like focal length will be 1 divided by diopter. So if we keep 2.5 diopter, then reading distance will be around 40 centimeter. So most of our near activity will be between 33 centimeter to 40 centimeter. So if there is 4 rad, then you can see that you have to bring things very close to you, and it will not comfortable distance, working distance for near vision. If you use 2.5 diopter, then it will give approximately 50 centimeter focal length, and then that spectacle dependence will be lost. Near vision will be slightly compromised. So in this picture also, you can see that in Auro Dfine, Aurolab multifocal lens, like distance distribution of light for distance is 47%, and which is close to Technics multifocal IOL. You can see distance, and in AMO Technics it is 41%. But it is for distance, restore is slightly superior, but for when coming to near, you can see that for near only 25% light is just distributed for near in restore. But in AMO techniques, it is 41% and Dfine also 35%. So both you can see that it gives good contrast sensitivity in both for distance and near, because light are equally distributed, almost equally distributed for both near and distance. And coming to defocus curve, if you see that in Aurolab Dfine, like +1 to -1.5 diopter, that log mark is 0.8. So it gives good intermediate vision also. Like if log mark is 0.2, so 0.2, so it will give you good intermediate vision. So you can see as contrast to other IOL, it gives a good intermediate vision also. So I will just go to the clinical outcome of Aravind EyeCare system. We have done around last year from Jan to 2024 at 3 centers like Madurai, Tirunelveli and Pondicherry. We have done around 1,298 cases. So I will just go through the outcome of that. So you can see that uncorrected visual acuity in this multifocal IOL, it was around 77% was within 6.6 to 6.6 partial, and 20% were between 6.9 and so almost 97% were having good uncorrected distance vision, and base corrected it was almost 100% fall within 6.9 vision. And coming to uncorrected near vision with multifocal IOL, so it was around 90% was where patients were having got N6 vision, and 10% got N8. So it is a very good vision. Around 100% patient fall within N8 category, and around 90% got N6 vision. And 1% patient were having some retinal pathology, so patient was detected in post-op operatively. So that patient doesn't get good vision, but it was also N10 vision. And coming to spherical equivalent, you can see that most of the 82% were having 0 spherical equivalent, and if you take 0.5 plus minus 0.5 diopter, so it will around almost 99% patient were falls under plus minus 0.5 diopter. So I will just share a video of one implantation of multifocal IOL. Here I am using 2.2 millimeter incision only. So sometimes if you do wound assisted, it goes easily in 2.2 also. But if you are using 2.8, you can implant it very easily. You can go inside also. So this cartridge, you can inject with 2.2 millimeter also, but the recommendation is 2.8. If you are using wound assisted, you can go through 2.2 millimeter also. So good 5.5 millimeter rexis and is required in this case, so that IOL centration is better. So I will go to the extended depth of focus IOL, that is from Aurolab. It is called Aurolab Vivid IOL. So it is a hybrid diffractive and refractive IOL, and it has a lesser number of zones. Like if you can see that only 4 zones are there. So it is mainly made for good intermediate vision. It is not for very for good near vision. And with a defocus of 1.5 diopter, most of the patient get 0.2 log mark value. And this diffractive zone is up to 3 millimeter, 3 millimeter central zone. So if you see that compared to trifocal, bifocal, this EDOF IOL give good brighter or good far vision, and intermediate vision is better in as compared to bifocal and trifocal, and near vision some amount of good like functional near vision it gives at from 40 centimeter onward, and range of focus is also better than both bifocal and trifocal IOL because it gives continuous range of vision. And like a spectacle dependence, if you see, patient will have means at 40 centimeter, patient will get good near vision, but for fine letter they have to use some glasses for this one reading and very fine letter, fine near vision work. And in lightning cutting condition, this lens perform best, and it is as compared to both bifocal and trifocal IOLs. And visual disturbance is much lesser as it has only central 4 millimeter, only 4 rings, and it is concentrated in a 3 millimeter zone, and central bull area is also slightly bigger than multifocal IOL, like it is 1.8 millimeter. So visual disturbance is like photic phenomenon as in trifocal and bifocal, it is less as compared to multifocal and trifocal IOL. So product specification, it is optic diameter is 6 millimeter and overall length is 12.5 millimeter by convex, and 3 degree angulation is there, and it is square is IOL, and a constant we can use 118.7 for optical ultrasound, optical biometry, and 118.4 for ultrasound biometry, and the optical design is both combination of diffractive and refractive technology, and it is force enduring haptic. It is stabilizes well inside the bag. And in this you can see that modular transfer function for this IOL in like it gives good contrast sensitivity for both distance and intermediate vision. So this IOL like if you compared with Eyehance Panoptics or BVT, it almost compared to both the IOLs in both range of light, like 25 lens per millimeter and 50 lamps per millimeter. So it performs almost equivalent to or better than these IOLs for both like intermediate and distance vision. And for the focus curve, it is also almost comparable to other like EDOF IOLs, and it gives a good range of continuous vision. And if you can see that at 40 centimeter, this Vivid is one step ahead of other IOLs, where you can see that at means it is closer to 0.2 log mark. So continuously, it gives almost a continuous range of vision from 40 centimeter onward. So this is our clinical outcome of Aurolab Vivid IOL. So from Jan to December 2024 last year, we have implanted around 631 IOL. So in this, like uncorrected vision was around 79%, having 6.9 and 6.6, because sometimes we use slightly, we are keeping slightly myopic biometry like 0.2 diopter of myopic, 0.3 diopter, so that patient will get slightly good near vision also instead of only intermediate vision. So we are making them slightly myopic, so that's why you can see that slight decrease in that uncorrected distance vision, but it is almost 97% patient got better than 6/9 vision, and base corrected vision also 93% got 6/6 partial vision. And going to like for intermediate vision, if you see around 70% of patient or 71% of patient falls under better than 0.2 log mark vision. So this gives good intermediate vision. And according to this one also, like WHO, if any like it extended of vision, IOL around it should give around 0.2 log mark intermediate vision. So in this category, it falls under good visual recovery for intermediate vision. If you can see around this 71% falls under 0.2 log mark, and almost 100% falls under 0.3 log mark. And coming to spherical equivalent, almost 76% patients were having 0 log mark, and almost 99% were between plus 0.5 to plus minus 0.5 to plus 0.5 diopter of spherical equivalent. So this is also just a video of vivid IOL implantation. It also goes in 2.2 millimeter incision very easily if you are doing wound assisted. Here you can see that only 4 rings will be there, and central bull area is larger, so that it for distance vision it never compromise distance vision. It will have good contrast sensitivity for distance, and intermediate vision that only 4 rings are there, that is distributed in 3 millimeter central zone. So in dim light also it performs very well, and very less glare and halos will be there with this IOL.
Thank you so much, Dr. Madhu, for sharing your experience and this informative talk with us on this clinical performance of continuous range of focus and multifocal IOLs. So with that, we will close this session. Okay, thank you so much again, sir.
Thank you, sir. Thank you. Nice meeting you. Thank you. Bye.
Thank you, everybody. I think a special thank you to Prof. Dr. Lim to be our moderator. Can we just give him a hand?
Thank you.
Yeah, fantastic moderation. So for the rest of you, good night. So see you all.
Seeing through the eyes of new possibilities, a vision called Aurolab.